David.
Thank you very much.
Cheers. Thank you very much, Dylan and Quentin, for putting on such a fantastic conference and also making the snow. It's been great. So I am actually going to be talking about CTPA. Nothing very much to do with skiing or injuries, but it's something very close to my heart, hopefully not very close to your heart by the end of this trip. I've called it epidemic or moral panic because there is obviously a lot of talk about the overuse of CTPA, and particularly for emergency departments, that maybe we overuse the test and maybe we're epidemically overusing the test. And I'm just going to go through some of the research that we've done recently to see whether that was an issue for us and whether it's a problem elsewhere in the world. Thank you very much to my fellow authors, one of whom, nothing like having a little bit of nepotism, so as you'll see there's another mountain, so we've got a whole range. Okay, sorry, I just have to point out that the previous talk was very triggering for me, that terrible tennis injury, because I've actually done that injury, which has ruined the whole Christmas. My wife didn't talk to me for a few days. Yes, I couldn't really watch it. I had to sort of cover my eyes. Okay, so why is this of interest to you? Well, most of you will be involved in managing or diagnosing PE at some stage. So the big ones are obvious. The little ones take a little bit more time. As I've already said, some of you may be investigated when you get back. If you've had a leg injury or get short of breath or a periodic chest pain. I've got no conflicts or acknowledgements, so it's a long time since I took drug company money or anybody else's money really, apart from you guys, so maybe I'll have to put that as an acknowledgement. And I'm very grateful to the guys who got the data for us and helped with the stats. I'm just going to talk a little bit about what we think we know and what we believe, and there's a lot of what goes on in PE and is about people's feelings about what it's like to diagnose and treat PE. We'll talk about what's happening in the US and then a little bit about what was happening in Western Australia, where I'm from, in Perth, Western Australia. I'll talk about some methods and results. I won't dwell on the methods, it's just to really prove that we actually did think about what we were doing when we looked at this. We'll talk about yield and compare it to a previous study that we did that was a multi-centre study in Australia. Whether the results were expected and whether there's actually evidence that this is happening elsewhere, and if we have a problem, what should we do about it? So this is Donald Rumsfeld. So this is the only philosophical quote for the talk. But so what we really don't know in PE is whether what we're doing in terms of diagnostics and investigation makes a difference to outcome, and that's the real unknown. We sort of think about it a lot. It really twitches us quite a bit. So we've done a lot more tests. We may be finding a lot more PE, but does it make any difference to the actual outcome for our patients? So what do we think is happening here? So I'm going to ask the audience to stick their hands up after each question if they believe that statement is correct. So the rates of EDCPAT use are increasing in your jurisdiction. So hands up if you think you're increasingly using CTPA. Yeah, that was about a third of the audience. Okay. You think that the increase is out of control and irrational. There's a few people who think that we're really out of control. And if you think that the positive CTPA rate, that's the yield you get from the test, is actually going down, so it's actually getting worse as we use it more. Well, that's actually, that's actually not that many people in the audience. That's either a lot of people who are just unwilling to put their hand up because they're tired. It's been a very long day skiing. Obviously, you always have to talk about the US because they are the big gorilla in the room for almost everything in the world at the moment, but certainly for diagnostic testing, they are very different from the rest of the world. And recently there was a USA national data sets which showed yield. They use an awful lot of CTPA, so 2.5% of everybody who walks into their departments ends up with a CTPA. That's not just a CT of the chest, that's a specific PE test for 1 in 20 of their, no, 1 in 40 of their patients. Their yield is very low, 6%. In some studies lower, in others I'll show you another study where they're even lower than that. Some places use up to 4% of their patients get CTPA. I mean, that's, as far as I'm concerned, that's brain dead medicine. That's everybody who walks in with anything related to their chest is getting a CTPA. And again, with yield that's pretty terrible. Jeff Klein, who's an absolute guru for PE, he moved to a new centre down in Texas, but he'd been working in Indiana before. He did a study to look at what the yield was for there, and their combined yield for two huge areas was 3%. That's only 1 in 33 of their CTPAs. But if you actually do the maths for that, so CTPA is not a perfect test. About 1 to 2% of them will be false positive. For their area, more of the studies are going to be false positive than they're false truly positive. And you really worry about whether they're actually diagnosing the PEs that are around, because really it's only 1.5% of the population that are tested are actually getting a PE found. And there's a lot more than that. If you look at ours and compare the numbers, we would be diagnosing 14 times as many PE as them from our much less use of CTPA. This is not a new phenomenon, so these studies are all the way back to 2000, I think, when CTPAs first started to be used, and the Americans have always been complete outliers. So they run around about the 6 to 10%, and sometimes a bit lower. Everybody else runs on the other side of 10%, so, and anywhere up to 20-25% in the older studies. Everybody's dropped back a bit as they use CTPA more, but we're nowhere near the level that the Americans are at. Why the US type testing is a problem is really what I just said before. The false positive rate, there's nothing you can do about that. All tests have things that give you false readings, look like a PE but they're not, and that's around about 2% for CTPA. Some other studies actually make it higher than that, make it very conservative. I'm not going to go through all the numbers, but basically you're getting very, very high numbers of people who are going to end up being treated with difficult drugs to manage, with high complication rates when they didn't have a PE in the first place. And I don't think that's a particularly good outcome. And in America, I think it's quite possible that you're more likely to not have a PE and be on treatment than if you've actually got a PE. So over to a different part of the world, Western Australia. So this is data. There's been a few studies from Western Australia. We're the same. I mean, we've increased the number of CTs that we do. Our yield has come down a little bit, but it's not come down that much. They use different surrogates, so it's admission to hospital with PE as a diagnosis. But we're still well over 10 to 12% yield and that was out to about 2014. They suggested that PE was getting less severe. I can't actually see it on their diagram that they published in that study. It actually looks like it's trending upwards after a little dip early on in the study. But also, death is a terrible marker for severity for PE. I mean, it's like nobody knows outside hospital, whether they've had a PE or not. We sort of just guess. If it sort of looks like a cardiac death, everybody calls it a heart attack, but significant numbers of those are going to be PE, and we know that's true from post-mortem data. If you're in hospital, we only diagnose about 25% of the PEs that kill people if you do post-mortem studies, so it's a very terrible marker for severity, death. And also during this period, CTPA was completely replacing VQ scan, so it's a very different sort of populations during that period. Yield had been dropping a bit, but not enormously. So, 22 to 19%, it was significant, but it's not an enormous drop. We looked at this data and didn't think it was as suggestive as they did that there was massive over-testing going on. They were very, very concerned, and we went, a little bit concerning if it carried on forever, but it's not terrible. We did a study in 2013-14 where we basically compared 14 different EDs around Australasia and looked to see what was happening with PE diagnosis, what the yield was. The fact is that when we looked at the numbers of PEs diagnosed, it increased absolutely linearly with how much you use CTPA. So in our population, the more you use CTPA, the more you found PE. And it wasn't disproportionate at any of the levels that we were. But we were using CTPA probably at about 30 to 40% of the rate that the US is using it. So there probably is a level where things start to get really out of control. Okay, so we decided to do some longitudinal data. So we'd already done the study, the respected study, in 2013-14, but I started to notice how many CTs were getting done in my department. So after about, 9-10 years, I was on the floor and noticing 5 or 6 CTPA results coming through in a day when I was doing results checking. It was after COVID, so we thought, well, maybe COVID's driven up the amount of use of CTPA. So we thought we'd look from 2014 to 2023, see if there'd been an increase in use of CTPA. And then, if that did increase, did we think that the yield came down the other way? So was the use warranted versus the rate of the population, the number of people coming into the ED, or was it excessive, well over the increasing rate of ED attendances? And if it was increased, then we presume that the yield would inversely reduce compared to the amount of increasing CTPA. It's only really important to say that we did actually sort of think of how to do it, make sure that we used rates rather than just the numbers, because obviously the number of people coming into EDs increase. We actually made sure that we did proper stats. We did some power calculations to make sure we could see a difference if it was meaningful. And we decided that a 3 to 4% change was a meaningful change in the rate. To go down to 1 to 2% differences takes an enormous number of people, and it's probably not that relevant anyway over a 10-year period. We did some clever stats, which my statisticians, thank you very much to them. So we did, as we talked about doing a power calculation, we needed about 700 cases to review. That's each of them are reviewed. We don't look at the actual study itself, the pictures. I look at the pictures because I quite like seeing if I can spot the PE, and that's useful. But in general, what we do is we just go off the result, because that's exactly how we manage patients in our department. We reviewed all the CTPA reports. The highest level of PE was documented, so if it's in the atria, then obviously that's where we document it, and we move down. And we group them into large, intermediate, or small PE. And we're particularly interested because what we want to know is whether subsegmental PE or isolated segmental PEs, the ones that are most likely to be false positives, if they're increasing in our population over time. And then we did some iterative reliability to make sure that we're actually reliably reading the reports. So this is the results for the longitudinal data. This is a fairly impressive sort of increase. So every year, pretty much. I don't think there was any year where it completely flatlined. Actually, interestingly, the first year was straight after our previous study did actually drop. So it started from a slightly lower base, but from then on, it's been a sort of pretty linear increase. There was a slight decrease during COVID for obvious reasons. People didn't want to come in, and people didn't want to take the scanners when they might have COVID. On the other hand, in other places, the number of CTPAs increased a lot because COVID is a prothrombotic disease as well. We did then do a secondary analysis where we then looked to see checked in 2019 whether there was a difference in yield before or after. So I'll show you those results as well. And that was the power calculation, which we needed about 700 CTs to review. And we overpowered slightly just in case. Not surprisingly, our population tends to be older, fatter, have more things done to it over time. So, you would expect a small rise in the number of PE. The demographics, slight female preponderance, which is a common occurrence for PE, particularly for younger patients. So that's what drives most of that, is younger women tend to get more CTPA. We expect around 1,100 CTPAs are going to be done in the final year of the study. And the age, obviously not surprisingly, people with PE tend to be older than people without PE. Okay, so the yield didn't change. So we'd almost doubled the number of CTPAs we'd done in numbers, and the rate had gone up by 70%, no change in yield. It's 0.6%. It's nowhere close. We didn't have to recruit extra patients for the study. And the numbers of PE that were per attendance that were diagnosed, 60% increase in the numbers of PE. So coming through RED, 60% more patients are getting diagnosed with PE as a rate, not just as an overall number. The largest vessel involved did change a bit, so the large PEs decreased, the intermediate PEs definitely increased, but the small PEs, the ones where you're really worried that you might have false positives, didn't change. So they were pretty much the same. So yes, there may be a change. The only thing I'd say about that is that in our previous study, the range of large was everywhere from 35 to 60% for the 14 different. So there's quite a bit of variability even from year to year, I suspect, in large and intermediate rates. We did look at 2019, as I said, just to see if COVID had really changed the dynamics. So maybe COVID was just creating so many more PEs, that's why we saw this sudden change in yield. So there are two reviewers, that was my daughter and me. 17.8% PE. So again, no change. If anything, more PE before COVID, so maybe there's a little bit dilutional going on because people are investigating more since COVID. And the large PE was 55%. And that wouldn't be a surprise because COVID actually makes smaller PE. It tends to be in situ PE, so actually clots that develop in the lung when people get COVID. So it may be that that's one of the reasons we're seeing a slight change from large to intermediate PE. So the increased PE rates are in line with more CTPAs being done. It's exactly the same at 2019 all the way through to 2024. Do we think the thresholds for testing have changed? Probably not, because we're really increasing at the same rate as we did all the way from 2014. And in fact, why didn't we do more testing during COVID? Because actually COVID truly was a prothrombotic disease and people do get PE from COVID, but we seem to be a bit resistant to doing more testing. The other thing that we did was looked at male versus females and age as a predictor of who gets PE and what your yield is. And to be honest, the only take home is that basically if you're young and female, everybody over investigates you horribly. And you've got a yield of about 3 to 4%. And nobody seems to be able to change that. So if you're on the pill, which is a minor risk factor, we've got to rule out PE. We'll roll out the big guns and everybody's going to get a CTPA. If you're pregnant, if you're, nobody can miss a PE if you're under 50 and female. But I think that is where, if we're going to change things in Australia, that's what we should be concentrating on, is actually finding ways of actually not investigating young females with a test that actually increases their breast cancer rate, a disease that they will be worried about in 20, 30 years' time, rather than continuing to do this when the yield is so terrible. I mean, that's like American practice, and I just, we cannot be doing that. So we've got to find some way of changing that dynamic. So that's that, and it's really, and that's obvious in any study that you do for women under 50. That yield is about 3 to 4%, never changes, and that's not acceptable for a test with those sort of other problems. So was that unexpected? As I said before, we knew that if we did more CTPA, we'd find more PE, certainly in the Australian environment, and we certainly don't seem to have reached that peak. We're at the very top end of that graph now, and we were in the middle of the graph before, but we've done more CTPA, we're finding more PE. If you go to the US, it's obviously not the reality there. The reality there is that they're horribly over-testing and seem to be blindly over-testing, and that's really concerning, I think, the way that's happening, because it shows no or very little clinical acumen or judgment, and I just don't think that's certainly not the way I'd ever want to practice. But I'm very pleased that ours looks like it's still, we're actually picking up the right people to actually do the test on. And Europe, Canada, Australia, New Zealand, Turkey, basically everywhere else in the world seems to be managing okay. So yes, everybody's increasing their use of CTPA, but it seems to be appropriately for people who present with symptoms that are compatible and with a significant risk of PE. There is some evidence that smaller PE, but again, it's not the really small PE. It's the intermediate PEs that are slightly increasing, the larger PEs, and there are lots of reasons why that might be the case, and I'll talk a little bit about that in a minute. So I don't think it's how many CTPA you do, it's how you decide to use your CTPA that's the important issue, and I think luckily that most of the world is still using their brain. So this is the trend in new PE rates in the UK, I think, over 17 years. As you can see, everybody's increasing the number of PEs that are diagnosing, so that's in the COVID caused a huge increase in the numbers of PE, which has settled back down, yet again showing how important vaccination is. So now that everybody's had either had COVID or had a COVID vaccine, the PEs have started to go away because it's your response to having COVID and the extreme response you get if you're not vaccinated that drives all the thrombotic disease, or most of it. So that's linked over there, obviously, on the right-hand side. And everybody has talked before about PEs or small PEs just being lung-linked, which is probably true. I mean, that's what lungs are for, basically plucking out bits of clot that have come, if they're small, it makes no difference to anybody. Occasionally it'll cause you a little bit of fleeting pain, and we don't really want to find lung lint. But I don't really think that most of the stuff we're finding on our CTPAs is lung lint. I mean, most of it's significant disease. We can't, as I said, there's some suggestion that things are getting, slightly less worse, so less people die. Well, we don't really know. We're not sure about that, but less people are getting admitted to ICU, and less people have large PE in some studies. We're not completely convinced about that in our population. In the rest of the world, almost everybody's seeing the same pattern, actually, that there's a lot more CTPA being done. Actually, the numbers of PE that are diagnosed are also increasing almost everywhere else in the world. And until about 10 years ago, the mortality rate looked like it was going down. But certainly if you're in the US and you're under 65, your mortality rate from PE has been increasing for the last decade. And we're not completely clear whether that's changed in the rest of the world. And there's some drivers for that. One of those, as you can see at the bottom end, the stuff that comes into the EDs now is actually more acute. So contrary to the nonsense about the fact that it's GP type patients that are overloading EDs, and we're all stuck there, so, you know, just surrounded by people with a few cough and cold. Actually, it's sick people with lots of other comorbidities and diseases that get stuck in our emergency departments. And it's no great surprise that they would also be more prone to getting PE, along with every other disease that they tend to arrive with. So I think that's probably one of the big drivers, is the increasing age and comorbidity of our populations. And these are some of the drivers. So age, and our population is definitely getting older. Certainly my population, I work in a very old, some of the other guys from other departments, I'm sure theirs are getting older, but Charlie's has always been a very old department, and it's getting older, but everybody's, you know, demographic is getting worse and older. People are getting more operations. So the orthopaedic surgeons have got fantastic treatments for almost everything. There's more and more joints that they can replace. They can replace them at different ages. You know, so that everybody is getting more and more operations, which is a very big driver for PE. People are surviving cancer, which is a great thing, you know, and they live for a long time on a lot of drugs that are all a bit prothrombotic, as is the cancer that they had in the first place. We're getting fatter, and you know, there seems to be no stop to that at the moment, so I think we're about 65% obese now, fat and obese, but in some countries that's still going up. We fly more. I mean, we're all flying a lot here, but you know, the air miles changed a little bit during COVID, but they've all zoomed back up again afterwards, so we're all flying around, which is a significant risk factor. And of course, there's a whole bunch of viruses. Almost every upper respiratory virus is prothrombotic to some degree. So flu definitely increases the rate of PE in people who get severe flu. And there's probably some unknown drivers or drivers. PFOS, we know, is definitely prothrombotic, so you know that's your non-stick pans, which are not non-stick ones. They will start flaking off, but everybody uses them until they fall apart. Microplastics, not clear yet how much they're related to thrombotic diseases. Estrogen mimics, which are common now in our societies. Lots of new viruses, some of which we don't really know about yet. We're quite sedentary, so obviously not this population. This population are obviously not sedentary, but the whole overall population is very sedentary, and that's probably its own risk factor by itself. And then obviously what we've been sticking into our mouths for the last 20, 30 years, obviously with the industrial complex that goes with trying to feed us a lot of processed food, and we don't quite know how prothrombotic that is. It certainly seems to be quite prothrombotic for heart disease, so there's no particular reason why the vein should be immune. And then obviously I talked about prolonged cancer survival. There are some things that have reduced, and I think that's one of the things that also drives the fact that we pick up smaller clots. Surveillance has increased. People actually think about the diagnosis a lot more. We actually do things to stop the diagnosis, so we actually use more heparin, put more leg compression on. So we actually go looking and doing things to try and stop PE happening. And we also stop smoking as much in the West, and we also have less pregnancies. So all things which are slightly prothrombotic. So that's a little sort of where you can actually, if you just stare at it for a little while, the circles look like they are rolling, but it's obviously a figment of your imagination, and that's probably true for quite a lot of small PE as well, certainly segmental PE. So it's really just a sort of an artefact that's quite difficult to exclude PE from. 15 to 25% of subsegmental PE or isolated segmental in our populations, probably about 10% of those are actually false positives, maybe a bit more. But it hasn't been going up, and I don't think that's the real driver for why we're seeing more PE in our population at least. So should we rest on our laurels and say, well, that's fantastic, we're great, the Americans are terrible? No, I mean, as I said before, I think if you're female, and certainly if you're female under 50, you should be very worried about the continued excessive use of CTPA in young populations. If we carry on increasing at the rate that we do, I mean, we might well end up at the 3-4% rates that the Americans are doing. If we do it sensibly and we're doing it for good clinical reasons, we're probably going to keep on picking up PE. But there are departments around Australia and New Zealand where well under 10% of yield in patients, and I don't think that's a good rate. That's not a rate where you would think that was acceptable. So everybody should be checking what they're doing in their own departments and trying to change things. Do we need to find them all? It's very difficult. Nobody with an intermediate sized PE should be left untreated. There's no guideline anywhere, and actually nobody can actually prove that you should leave subsegmental PE untreated. I mean, everybody's tried and thought about it and said, well, we probably shouldn't treat these, but they can't actually prove it. So currently there's no real evidence to stop you treating a PE that's been diagnosed on CTPA. So, moral panic or an over-ordering epidemic? Well, if you're in outside the USA, I think it's more moral panic than actual problem. So as long as you've got sensible ordering, good senior coverage and whatever, you will probably use CTPA reasonably sensibly, and that's probably true for most of the rest of the world. If you're in the USA, there's an epidemic over-testing going on, and you should be very worried about the practice of medicine and the use of CTPA that's going on in that environment. Thank you very much.
Has anyone got a question for Dave?
Yes, I'll run a microphone to you. Thank you.
Thanks very much for your excellent talk. Can you talk a little bit more about the young women under 50, and particularly the pregnant ones? I always get scared with pregnant people, and I find it really hard not to over-investigate them.
Right.
So, any wisdom on that?
It is difficult. Nobody wants to miss. There's two patients. It always looks catastrophic. There's so much literature about the fact you mustn't miss PE in pregnant women, and the obstetricians are every patient from King Edward's, our local, comes to us with CTPAs, and they come with all sorts of weird and wonderful symptoms where you're going, what the hell? But we have no real control on that, so that's one of the reasons our rates are so low. I still think that you need to talk to them. If the patient it's again about patient decisions, but they start at a 3% rate of actually having a PE, and that's absolutely true for the women who are pregnant. So we've looked at the King Eddie's group. So they had a 3% rate of PE. That makes you very low. All you need is something else to basically drop you a little bit, and you are safe to let that patient not have further investigation. You could do an ultrasound of the leg to make sure that they don't have any DVT if they're very low risk. Check their symptoms, see if they've got reproducible pain. It's not saying that you shouldn't ever do the test, and clearly there are patients who are going to have PE. But I just think we need to go in with the mindset that actually this is still a low risk population compared to all the other people who are coming through, and try and work out ways to avoid doing unnecessary testing in those populations if we can. It's not easy because you can't do D-dimer for most late pregnancy, at least. Anything after 20 weeks, 25 weeks is pretty useless because everybody's got a raised D-dimer, and there's no guaranteed D-dimer level where everybody's agreed that that's safe as well. It's not easy. I think for young women without pregnancy who are on, just on the pill or whatever, I think there we have to really go. You have to really make the case, why am I going to do the test on this patient? Because the start risk is so low in that population.
Big boys back there, Matt.
Specific to that population, is there ever been a study of what would happen if we anticoagulated the young women with potential PE as if they had one, the risk versus benefits? Would that be something?
just anticoagulate everybody who's pregnant.
Not who's pregnant. The young women that might have a PE, if the yield is only 4% of CTPA, could you make the argument that you just chuck them on a NOAC and see what happens?
Not really. I mean, but all the current guidelines are at least 3 months and NOAC is your first dose. No, there's no study saying reduce to 4 weeks. So I mean that would be horrible over treatment.
That's right.
And you'd only need the first leading death in that population to. I don't think there's any real way that that's going to work. I think you just have to try and work out how am I going to avoid doing this test in this population.
Thank you. How do you know your false positive rate?
Well, so the false positive rate. So all our scans are obviously done by anybody in the department who wants to have a look at the scan because they're on for that day. So that's 28 consultant radiologists, maybe more. But they're not specialist cardiothoracic radiologists. So most of the studies where they get specialist cardiothoracic radiologists who are used to looking in detail at the lungs will go back through and they do multiple studies where there's 3 of them and basically they read, cross-read, and then eventually if they're still in disagreement they confer. But basically these are guys who look at these things all the time and are very good at looking at the vessels and going, actually that's just artifact, that's cut off. So when you do that, you find very high rates of false positives. I mean, some studies are up at 50%, where they would go, we're happy, that's a consensus agreement, there is no PE there. And then, others are down about the 20-25% for isolated subsegmentals. But, they're very high rates. And actually, it's really interesting when you go through the radiological literature. That's true for a lot of things like subdural or extradurals. There are false positive rates up to 20% in those patients. That's miss and overdiagnosis because the little skinny ones are always hard to pick, and they confuse people who don't do that as their every single day of the week, or they're just having a bad day, like all of us are prone to.
Any other final questions?
Can we ignore treating small P's?
Pardon?
Can we ignore treating small P's?
Well, that's the real problem is that nobody's done a definitive study. Carrier in Canada tried to do that. They actually couldn't meet their own start hypothesis that it would be less than 5%. Sort of like follow-up problems. So they were over 5%. So even though they were not treating subsegmental PE, they eventually went, we can't justify that because we haven't reached our own initial criteria. There's other studies that have followed up subsegmental PE, and it's not the actual subsegmental PE. Almost nobody dies from a subsegmental PE unless they've got terrible, cardiothoracic disease in the first place. It's the follow-up clot that kills them. So if you're not on an anticoagulant, but you still had a DVT or some other source of clot, it's the follow-up, disease that might get you. Eventually, we've got to find a threshold where we go, well, actually, this is such small disease, it's not worth treating, but nobody has been able to find it yet. I know I keep looking for the study that's going to sort of allow us to avoid it. I mean, the only thing is DVT, where sometimes a calf DVT you can leave, but even that, there's a bit of overpush as well for treatment in the thrombosis community, but even that's sort of harder and harder. I mean, they're treating thrombophlebitis, which is pretty terrible, I think. Anyway.
How do they determine less than 10% yield was a good rate? Is that a rate at which mortality and morbidity is low enough for us to accept?
Can you repeat the question for me?
You mentioned that less than 10% yield was a good yield to detect PE. How did they come to that number?
How do you work out that your yield is less than 10%?
Yeah,
Well, it's the same as we do. Basically, you,
Why is that a good number? Why is 10% or less a good
well, actually,
yield?
it's really less than 15%. Is the sort of around the area where people think that that's the benefit from the test probably outweighs the false positives and the. But it's sort of a bit of a guess. You know, there's actually only one paper that's actually put a number on it, but sort of everybody's sort of ended up hovering around about that. So that's the British College of Radiologists said 15.5% was their number. Not based on a huge amount of sites, I've got to say, but actually if you then look at how the test works and performs, much below that, if you're under 10%, you've got a lot of false positives. You know, 20% of the people you're diagnosing will get treated unnecessarily. And again, if you there's other papers by Jeff Klein and a few others where basically if you're under 80% certainty for PE, you shouldn't really be treating the patient. You should be doing a further test or trying to work out what's going on. So I think under 10% you can be pretty clear that you're not really using the test optimally. You should probably, you know, find ways to improve it. And a lot of the time, if you actually look at departments, I mean, our department uses an algorithm, proper testing, you know, does a pre-test probability, uses D-dimer fairly extensively, and departments that use those things more have better yield and better outcomes and use less CTPA. So there are normally things you can do to improve what you do at a local level if you are, you know, have a low yield.
Thanks, Dad. The graph, the linear graph with the yield steady and increasing use. I think you asked when's that going to level off? Are we all going to get CTPAs and PEs eventually, or when do you expect that to flatten off?
So it's one of those interesting things. I mean, I think everybody would have thought that we are heading the same way as the Americans, you know, with that increased use and whatever. But in our populations now, EDs are not obviously a clear representation of the whole population. We're a representation of the people who get out of general practice and community land stuck into hospitals. And so it may well be that actually what's happened is that, and we sort of know it's true, the graph below, the low yield, you know, general practice type patients are disappearing from our EDs, and we're actually seeing sicker and sicker patients. So in some ways, I don't think it's that big a surprise perhaps that we're actually seeing more PE, because if you actually look at the protoplasm that's coming into our departments, they are sitters for PE, literally in many cases. So, you know, it doesn't surprise me that much when I think about it a bit more about what I see as the change in demographics over my 30 years in emergency medicine and the sort of patients I used to see and what I see now as my bread and butter patients. They're a very different set of cohorts.
What's the difference between Western Australia and the United States in the decision making for the testing to be initiated?
Well, I mean, if you look at the average department in the States, there's an absolute antagonism towards using any form of guideline or pathway. Everybody's allowed to do whatever they, you know, so that exceptionalism, individualism, I think is part of the reason. There's a real fear in missing. I mean, they're incredibly legalistic and frightened to miss anything, and therefore there's horrible over-ordering of tests. But that's true in other societies that have less of a problem. Germany, Japan, you know, because they have so many machines and there's so many incentives to use those machines, they're always doing, you know, too many tests. But they don't have the same terrible yield that they do. So what's different? I mean, we're not America. I mean, I think that's what's different. I mean, there is a mindset and a cultural difference about how you use tests and how you approach a patient. I mean, it's always, I mean, we still teach, and I think rightly, that it's the history in the exam, you know, it's 90% of everything you need to know about a patient is there. The tests are just confirmatory or exploratory, you know, for the occasional miss or the occasional difficult patient. And that's, you know, it's good that we still have clinical